Hi, I'm Cindy Rapp from Denver, Colorado, and today I'm going to be talking about optimization of breast ultrasound. Today we're going to be talking about optimization of breast sonography. Now with breast ultrasound, what our general goal is to make a more specific diagnosis than what can be made with the clinical and mammographic findings alone. More specific goals that we try and accomplish is to prevent unnecessary biopsies. If we can show that what the patient is feeling is a ridge of normal fibroglandular tissue or a simple cyst, we can avoid having the patient have a biopsy. We also try to prevent follow-up for mammograms. It's amazing how many patients are afraid of the amount of radiation that they think they're going to get from a mammogram. So if ultrasound could answer their concerns or problems and additional views for the mammograms don't need to be done, that's a great goal that we can accomplish. We try and guide interventional procedures. If a lesion can be seen under ultrasound, it's going to be much easier to biopsy it under ultrasound guidance than it is stereotactic methods. To improve the clinical and mammographic interpretive skills. And what I'm going to do is show you an example of an area on a mammogram that was given a BI-RADS 4. We scanned the same patient with ultrasound and changed that BI-RADS classification to a 2. Now anything that's a BI-RADS 4 or 5 is recommended for a biopsy. With the BI-RADS 2, basically it's saying that the area is perfectly normal tissue and no further workup needed to be done. And the last thing I put here is to find malignancies missed by the clinical and/or mammographic exam. I'm not saying that ultrasound is here to replace mammography. That is still our screening modality of choice. But I'm sure all of you have had a patient that had a, quote, negative mammogram that we were able to find a breast cancer with ultrasound. If we look at the indication as to why we're doing breast ultrasound, number one indication is a palpable abnormality. About 46% of the time, patients will present with something palpable that we scan for ultrasound. You can see we have mammographic 32% of the time, follow-up 7%, the one we all hate, pain. Yes, pain is an indication for doing a breast ultrasound, but it's kind of a time where you can help educate the patient to let them know that rarely is breast cancer tender. Most of the time, it's something that shows up on the mammogram or a palpable abnormality that they'll present with. And if a patient presents with pain, majority of time it's due to hormonal reasons and not an actual mass. Then the final thing is non-targeted. This piece of the pie is scanning just for a specific lump or mammographic density. And I think we're seeing more places doing whole breast ultrasound and not just a targeted breast ultrasound. With the concerns of patients that we see today, more of them want to have a whole breast ultrasound. First thing we're going to talk about is proper equipment. Now in doing breast sonography, you need to make sure you have a transducer that has excellent near field resolution. You want to have good spatial resolution. This is axial and lateral, and also good contrast resolution. We're going to talk more about lateral resolution. This is what's going to help minimize volume averaging. When we look at the transducer, there's basically two planes to the transducer that we deal with. The long axis of the transducer, and things that can help minimize volume averaging in the long axis are your focal zones. If you're looking at a lesion that's superficial, move your focal zones up to the near field. If you're looking deep, move your focal zones down. But adjusting your focal zones is going to help optimize your image and avoid volume averaging. The other area of the transducer that we basically have no control over is called the elevation plane. This is going to be the short axis, or where the beam is going to be focused in the narrow view. And if we look at a high frequency linear array transducer, if we have a lesion that is sitting right at 1.5 centimeters in depth, and that's where most of your high frequency linear array transducers are focused, you can see that the beam is narrower than the lesion. If this is a cyst, it's going to appear cystic. If you have a solid lesion sitting in this area, you're going to see subtle differences between that and the surrounding tissue. Whereas if you're using a low frequency linear array transducer, such as a linear 7 to 4 megahertz, those are intended for peripheral vascular imaging. Those transducers are focused right at about 3 centimeters in depth, and on most patients, that's just about at the pectoralis muscle. So in using your lower frequency linear array transducer, what you're going to notice is the lesion, the beam is wider than the lesion. If you have a cyst, it will fill in where that goes and look like it's solid. If you have a solid lesion, you may not even be able to differentiate that from the surrounding tissue. It just becomes sort of volume averaged into the surrounding tissue and you may not even notice it. So here's an example of a lesion that is scanned. It's very superficial. In fact, on this patient, 1.5 centimeters of depth is right at her pectoralis muscle. We can see this lesion here, and basically, I would have to classify this as indeterminate. I'm not sure if we're dealing with a cyst, if we're dealing with a solid lesion with necrosis. You just can't be certain because a lesion is too superficial to the skin. We want to do something to get it closer to the elevation plane focus. So in doing that, we've taken a Standoff pad, moved this closer to the 1.5 centimeters in depth of the elevation plane focus, and now you can see that what we have are two simple cysts sitting adjacent to each other. And you're like, wait a minute, Cindy, that looks like it's a lobulated lesion. You said two simple cysts. Well, on ultrasound, we don't see structures that are running up towards the transducer real well. A 0-degree angle is our best angle for Doppler, but it's our worst angle for imaging. We see structures that are parallel to the transducer face, so something that's 90 degrees will cause a bright specular reflector, and we're going to see that a lot better on ultrasound, but if it's running straight towards us, we typically don't see it as well. Next thing we're going to talk about is patient positioning and annotation. Now, in scanning the right breast, most areas that we scan are in the upper outer quadrant of the breast. So we're scanning the patient's right breast, we'll roll them in an opposite posterior oblique or an LPO projection. If I'm scanning the medial aspect of the breast, a lot of times what I'll do is roll the patient supine. And if I'm scanning a patient, a large breasted patient, and looking at a lesion that is lateral, sometimes I will roll them almost in a decubitus position all the way. And then what we're trying to do is thin the tissue planes out as much as we can. So having the patient bring their hand up and behind their head is going to help thin the breast and allows us to image much better. That even in fairly large breasted patients, once we roll them and raise their hand up over their head, we're thinning the tissue planes out, that rarely do we have to scan beyond about 3 to 4 centimeters in depth. Kind of a good rule to remember that if you're using your high frequency linear array transducer and you're trying to image something at about 5 centimeters in depth, you're pushing that transducer too far, that you may need to increase or go to a lower frequency transducer to be able to see lesions better in the deep field. Now, as far as annotation, most lesions in the breast we use the clock face, and then if you're scanning something that is solid, typically, or any type of lesion that we're going to do a follow-up, we will document centimeters from the nipple out. If I am scanning a patient and I see multiple lesions that are just simple cysts, I will use what I call the ABC 1, 2, 3. So looking at that, if we have a lesion that is close to the nipple, we consider that area 1 in the breast. Lesions that are midway out, we will label area 2. And if a lesion's in the periphery, we consider that to be 3. So in annotating, I will also label SA for subareolar if I'm scanning a lesion behind the nipple, and AX anytime I'm scanning in the axilla. In typing this out, I will type right 12 o'clock 2. It tells me I'm in the right breast at the 12 o'clock position, halfway out in the breast. Then what I want to do is look at the depth. If a lesion is very superficial, just under the skin, we call that area A. For lesions that are midway down in the breast, that will be B. And if a lesion is deep in the breast, up against the chest wall, we will label that area C. So now in annotation, what I'll type in is right breast 12 o'clock 2C. Lets me know that at the 12 o'clock position, halfway out against the chest wall, is where I will be able to see the lesion. So just sort of in review, you can see the 1, 2, 3 and the ABC. Just another example of scanning a patient in the right breast at 12 o'clock and the left breast at 1:30. This would be the 3B because it's clear out in the periphery and halfway down through the breast. This would be 12 o'clock 2C, halfway out and up against the chest wall. Now, as far as scan planes, pretty much everything in the body we scan in a standard longitudinal and transverse scan plane. When we look at breast cancer Breast cancer likes to take the path of least resistance. So if I scan this lesion in my standard longitudinal and transverse, you can see that the lesion looks fairly well circumscribed. With breast lesions, what we prefer to do is scan it in a radial scan plane, very similar to the spokes of a bicycle. And anti-radial is just rotating your transducer 90 degrees to whatever the radial scan plane is. This way we're able to pick up these subtle projections of duct extension or branch pattern that may be coming out within these lesions that like to grow through the ductal system. This is just a diagram of showing you scanning the right breast at 1030, a lesion at 3B in a radial scan plane, rotating the transducer 90 degrees and scanning in an anti-radial plane. Looking at normal anatomy with breast ultrasound, the first structure that we're going to scan will be the skin. It will be just underneath the transducer face, and it should be echogenic, about 2 to 3 millimeters in thickness. We then have the subcutaneous fat that's seen just underneath the skin. There's a pre-mammary fascial layer. This fascial layer extends all the way up. Wherever there's a Cooper's ligament, it goes up, attaches at the skin, and comes back down and continues on. We then have the Cooper's ligaments, as I mentioned earlier, that we can see extending through the fat. Cooper's ligaments actually attach back at the chest wall, extend all the way through the breast tissue and up to the skin. We then have the mammary zone, and we're fortunate this is where the majority of breast cancers are going to occur, is in these structures here called a TDLU. And on a lot of patients, that's just about 1.5 centimeters in depth where our beam is focused the narrowest. We then have a retromammary fascia that we really don't see very well sonographically. There's a retromammary zone of fat and all the way to the pectoralis muscle. So when you first start imaging, you want to make sure that you can see all the way to the pectoralis muscle, that you're not cutting a lesion off if it is deep against the chest wall. So just showing you examples. Here we can see the skin that is echogenic. We have the pre-mammary fat. We can see a Cooper's ligament extending up. And here is our mammary zone down to the pectoralis and then actually down to the lung through here. Now, looking at this pattern, I've heard some people refer to this as ductal ectasia. This actually is not ductal ectasia. In fact, if you notice, we have a small normal duct here surrounded by periductal stromal tissue. So when you see this pattern that kind of looks like Swiss cheese, what we're seeing is actually the normal duct, which is right here in a short axis view. This is rotating 90 degrees to the long axis view of the normal duct. And this is the loose periductal stromal tissue that surrounds the duct. This is what allows ducts to expand and contract during lactation. And this is a pattern that you typically will see in women in their 30s to early 40s. Typically before that, they have more of a glandular breast pattern, which is sort of gray, and then the older women get the periductal stromal tissue tends to atrophy and just sort of blends in with the normal surrounding tissue, so you typically will not see it after that. What we will see with ductal ectasia, these images here are a normal completely collapsed duct. Here's a duct with just a little bit of fluid and a duct with a little bit more of fluid within it. We really don't get concerned about patients with ductal ectasia unless they are symptomatic. If they're presenting with abnormal nipple discharge, then we will look in the ducts for papillomas and ductal lesions within there. But 50% of the women over age 50 will have some ductal ectasia, so it's something we really don't get concerned about if they are asymptomatic. We're going to talk a little bit about normal variations and age changes that we see when a patient is scanned. And this is sort of what a normal patient with a lot of fibroglandular tissue will look like. You'll see that there is the pre-mammary fat layer, the skin down to pectoralis muscle, and quite a bit of the fibroglandular tissue. What we see with age is more of the pre-mammary fat is increasing. You can see the fibroglandular tissue we're not seeing as much, and if you notice, we're seeing more retromammary fat behind that mammary zone to the pectoralis muscle, but you can see Cooper's ligaments extending up quite nicely in this fat. As we progress on, you can see that there is more fatty infiltration into that pre-mammary fascial layer. We have a decrease in the amount of the mammary zone, more retromammary fat all the way down to the pectoralis muscle. And here we can see even more pre-mammary fat There's just a little bit of the fibroglandular tissue that we can see down to the pectoralis muscle. You can see Cooper's ligaments extending up very nicely up against that gray background of the fat that we're seeing, all the way into a completely fatty involuted breast, where here we have the skin, here's kind of the pre-mammary fascial layer, and the entire mammary zone is filled in with fat that we really don't see any fibroglandular tissue in this completely fatty involuted breast. So just sort of normal variations that we see with age change or hormonal changes, from a normal breast to where there's a little bit of fatty infiltration into more, and all the way into complete fatty involution of the breast. Now, looking at mammographic-sonographic correlation, there is one difference between breast sonography and when we look at the mammographic algorithm. That is operator dependence. I've always said that breast ultrasound, or any type of ultrasound, is only as good as the person holding the transducer. When we look at mammograms or mammography, obtaining the good images is actually fairly easy. There's a lot of excellent mammography technologists that know all the right angles and positions to put the patient in to get these great mammographic views. What is difficult is for the radiologist to interpret those, where with sonography, it's just the opposite. Getting a good view is what is difficult. Knowing exactly how much pressure, getting the right angle, making sure that you're directly over the lesion, that you're not creating something. Once you get the good picture, making the diagnosis is fairly easy, but being able to find the lesion and get the good pictures of it on ultrasound is actually what is more difficult. When we look at mammographic-sonographic correlation, we compare our scan planes. The transverse plane of ultrasound is basically the same as what we're going to see on the CC projection of the mammogram. So I used to take patients' film and sort of hold it up underneath my own breast, and I would say, okay, my CC projection looks just like what I'm going to see on ultrasound. If it's on the medial aspect, I know that that's where I'm going to be scanning, is a medial aspect of the breast on ultrasound. What is more difficult on comparing mammograms to ultrasound is looking at the MLO view, the oblique projections. It's less predictable because we don't know the degree of obliquity that the MLO was projected at. And so it becomes more difficult in figuring out exactly where lesions may be in looking at that. When we look at the correlations of mammography and sonography, lateral lesions appear to be located more superiorly than they really are on the MLO projection of the mammogram. And the more peripherally that they lie, the higher they're going to project on your MLO view. Just the opposite is true for medial lesions. They're going to appear to be located more inferiorly than they really are in the MLO, and the more peripherally they are, the lower that they will be. You know, I've always had a hard time in remembering this, and how do I figure out which is which? So the one way I remember it, muffins rise. If you're on the medial aspect, you need to look higher than a lesion really projects on the mammogram. And remember that lead sinks. If you're lateral, you need to look lower at lesions. So it's kind of how I remember medial lesions are going to be scanned higher than they really project. Lateral lesions, you need to scan lower than they project. So in breast sonography, when we compare mammograms, mammography, there's three densities that we deal with. There's fat, and fat is anything that is gray on the mammogram. Calcium, this is a benign calcification. And the third density that we deal with mammographically is called a water density. A water density is anything that's white mammographically. So in looking at this lesion here, we have a mammographic lesion. It is a water density, and this is where ultrasound is most helpful in looking at that and determining exactly what we're dealing with. What are all the things on a mammogram that can make up a water density? The most obvious is a cyst. Also normal fibrous tissue and normal glandular tissue, and we can see the fibroglandular tissue through here. Any solid nodule, does not matter if it is benign or malignant, are water densities mammographically. And then also your muscle and skin. We can see a little bit of muscle here. We know obviously this is not muscle or skin, but muscle and skin are also water densities mammographically. So in looking at this patient that presents with a palpable lump, you can see there's a BB here in the left aspect of the CC projection of her mammogram. Is ultrasound going to be real helpful in this patient? Not really. So since it was something palpable, we went in and did the ultrasound. You can see here's the skin, here's the premammary fascial layer, here's a Cooper's ligament. The entire mammary zone is completely filled in with fat, and expect to see something like this. This is where mammography is the most sensitive in looking at fatty involuted breast. A lot of times when the patient has a palpable abnormality, what they're feeling may be a Cooper's ligament, or maybe they just feel a fat lobule, but mammography will be the most sensitive in dealing with fatty breast tissue. And you really don't need to spend a lot of time looking for a lesion, because if it was there, it would not be missed on the mammogram. Looking at mammographic-sonographic correlation, here we have a very dense mammogram, also a palpable lump in the left breast. We scan this patient on ultrasound, and you can see here's the skin, and then the entire breast tissue is all just sort of low-level gray. And you're like, well, it looks like fat, but there's no way it can be fat because we have a very dense mammogram. We know that fat on mammography is going to be gray. What this is glandular tissue. This is either a very young patient, somebody in their teens, normally you wouldn't be doing a mammogram on, or it is somebody who is lactating or pregnant. So a lot of patients, you can see why mammography is not very sensitive in patients that are lactating. They have a lot of glandular tissue, and glandular tissue on ultrasound tends to be the gray tissue that we'll see. Here's a patient with another mammogram that's very dense, palpable lump on the right side. And this is a patient that we see a lot of fibroglandular tissue. This is where ultrasound is the most sensitive in dealing with patients with this fibroglandular tissue. If you have an isoechoic lesion, it will jump out at you. It's going to show up very well when we've got that echogenic background to scan lesions on, so this is where ultrasound is the most sensitive. Now, if the patient's had a mammogram, we want to compare 4 things on the mammogram with what we're looking at on ultrasound. We want to look at the size of the lesion, look at the shape of it, figure out the location, and look at the surrounding tissue. If the lesion that you're seeing on the mammogram is surrounded by fat, then what you're scanning on ultrasound should also be surrounded by fat. So the first thing is looking at the size. When you're looking at the size of a lesion, take into an account everything that's a water density on the mammogram. So I know that I'm going in to look for a 2 centimeter lesion on the mammogram, and when I'm scanning, all I can find is a 1 centimeter cyst. Well, if that 1 centimeter cyst is surrounded by a little island of fibrous tissue, that may be why your size does not match up. So typically what I would do in this case is measure the cyst and then just take one more caliper and measure across, including the fibroglandular tissue. But you can have a 2 centimeter cyst, a 2 centimeter fibroadenoma, an area of fibrous tissue, or any lesion surrounded by fibrous tissue that may account for why we're looking for a 2 centimeter lesion on the mammogram. The other thing is when we look at the size of a lesion, how do we measure? We all know that if you're measuring a BPD, it's leading edge to leading edge. If you're measuring an aorta, outside to outside. Measuring common bile duct, inside to inside. But with breast ultrasound, a lot of places, people will just measure the inside or the fluid of a cyst. Some people measure on the outside and include the capsule. The one thing that you want to do is make sure everybody in your department is measuring the same. And in our department, we do include the capsule on all of our measurements. If we're trying to correlate mammography to sonography, the capsule is a water density. But the biggest thing, make sure everybody in your department is going to be measuring things the same. Now, looking at mammographic-sonographic correlation, here you can see that there's this area of lesion appears to be in the left lower portion of the MLO view. Go in and scan on ultrasound, and you can see that there is this area of fibrous tissue. This is a pseudomass created by fibrous tissue. It's probably the most common question I get asked is people will say they can see a view on a mammogram and they go and scan on ultrasound and can't find anything. Well, remember, take into account everything that's a water density, and perfectly normal tissue can create a pseudomass. So what this patient needs to do is have a spot compression view just to make sure that the tissue smushes out. Anytime we're calling something asymmetric tissue, we do a split screen image. You can see that on her right MLO view, there's this area of fibrous tissue. We have the same area of fibrous tissue here on the right side, and this area of accessory fibrous tissue right there, creating a pseudomass on the mammogram. Looking at the shape of a lesion, we will see a 90-degree rotational difference when we compare mammograms to ultrasound. Think about how a mammogram is done. The breast tissue is pulled away from the chest wall and compressed down. With ultrasound, we have the patient lying flat on their back, and then the normal weight of the breast tissue is compressing the breast. So looking at mammographic-sonographic correlation and looking at the shape, lesions on a mammogram will appear to be perpendicular to the chest wall mammographically. When we scan the patient on ultrasound, that same lesion will rotate 90 degrees and now be parallel to the chest wall. The other thing is looking at the shape and location. Lesions on an ultrasound will always be closer to the chest wall on ultrasound than they are on mammography. The breast tissue is being pulled away from a mammogram and being compressed down on ultrasound. So here we can see there's a lesion. It appears to be several centimeters from the pectoralis muscle. Once we scan the patient with ultrasound, we can see that it's actually indenting into the pectoralis muscle. So you'll always see more retromammary fat mammographically than you do sonographically, and that's just because our breast tissue on ultrasound is being compressed down. This is a patient on their mammogram, sort of a coned-in view. You can see this area of fibroglandular tissue, and there's an area that peaks up here into the supramammary fat. If we look at this, this is an area of architectural distortion. There's nothing that should be peeking up into the fat there. Mammographically, this is given a BI-RADS 4 classification. Now, anything that's a BI-RADS 4 or 5 is typically recommended for a biopsy. So we scan this patient on ultrasound, and it's always hard to get a single projection of an ultrasound that shows what you're seeing real time on ultrasound, but in looking at this, we have this area of ductal ectasia that extends up into the fat and comes back down. If you notice, we have fat that's anterior, same fat that we can see anterior. His is ridge of fibroglandular tissue, same ridge of fibroglandular tissue. Size, shape, location, surrounding tissue all match up. We've taken what had been given a BI-RADS 4 mammographically and turned that into a BI-RADS 2 on ultrasound, and basically this patient does not need any further follow-up. This is the one I think all sonographers absolutely hate. You can see this one little mammographic ditzel do. It's in both projections. You can see it on the MLO and the CC view, and this happens to be the patient that had her mammograms done on a 14x17 film. And basically you get the short straw. So you start scanning, looking all over. You know it's in the upper outer quadrant of that right breast, and you can't find anything. If you can't find it, most likely you're dealing with a solid lesion. So what can be helpful is to look for the capsule that surrounds it. But another thing that I've learned that can be very helpful, if we think back to our Anatomy 101 classes, what are the three structures that run through the breast, or actually through the body together? It's your lymphatics, your blood vessels, and your nerves. In fact, you can see there's this little lymph node here, and here we have this blood vessel adjacent to it. So one thing I've learned is if you turn on color Doppler, find a blood vessel in the upper outer quadrant of the breast, sort of start up near the axilla, scan down into the breast, and with that color Doppler turned on, a lot of times those blood vessels may lead you right to these small intramammary lymph nodes that are very difficult for us to see because they are isoechoic to the surrounding tissue. If you can't find it with ultrasound, then what we typically recommend is that the patient gets a 6-month single projection mammogram follow-up, not another ultrasound, or you'll drive all your sonographers crazy. System optimization. Now, when I talk about a lesion being isoechoic, what am I referring to? You know, early literature compared everything in the breast to fibrous tissue. Well, fibrous tissue on ultrasound is this bright white stuff that we'll see. So if I compared everything to fibrous tissue, everything would be hypoechoic to that. One thing that we want to do is find something that every patient will have, and something that we can call about on the 50-yard line. And that one thing is fat. So we compare everything in the breast to fat. If I say a lesion is echogenic, it's brighter than fat. If a lesion is isoechoic, it's equal to fat. And if a lesion is hypoechoic, it's darker than fat. If you're only going to listen to one thing about this whole lecture, this is the one thing to make sure that you have. Always set fat at medium gray. Make sure that when you optimize your machine, you find an area where there's fat and you turn it so that fat is medium gray all the way from skin line down to the pectoralis muscle. Here we have an example. You can see what looks like a cyst. Nice, good borders, nice through transmission, but one problem. What color is fat? Fat set is black. So once I turn my fat back so that it's medium gray, is this truly a cyst? We can see all these internal echoes. And once I actually show you a different projection, this is rotating my transducer 90 degrees. There are obvious malignant features within this lesion. This one image here was a cut taken right through this portion of the lesion. But what we're seeing, this is a high-grade invasive ductal carcinoma. Just because there's enhanced through transmission does not mean that you're dealing with a cyst. Your high-grade cancers has as much enhanced through transmission as a cyst does. So yes, shadowing is something worrisome for malignancy, but just because you see enhancement, that is not reassuring that you're dealing with a benign lesion. Next, we're going to talk about palpable nodules. Now, with palpable nodules, remember our number one goal in ultrasound is to try and prevent an unnecessary biopsy. If we can show that what the patient is feeling is a simple cyst, a fibrous pseudomass, a complex cyst, or a fibroadenoma, we can avoid having the patient have a biopsy. So looking at these lesions, if the indication is something palpable, even before you start scanning, make sure you feel the lesion. It's going to tell you a lot about what you're looking for. If it feels like it's a BB, you know it's going to be very superficial, so you need to worry about your elevation plane focus, using a standoff pad or extra gel to get that closer to the standoff. The next thing is, while you're scanning, make sure you take your finger and run it underneath the transducer. Make sure that what you're seeing and what the patient feels is the exact same thing. The number one palpable lump is a ridge of normal fibroglandular tissue. This is more common than a cyst or anything. Now, any patient who comes in your department for an ultrasound because they feel a palpable lump, in their mind, they just know that they've got breast cancer. So if you're allowed to talk to your patients and let them know that what they're feeling is normal tissue, you're going to make their life much easier that day, because in their minds they think they've got breast cancer. One thing you want to make sure that if they're going to follow normal fibroglandular tissue, they check that area once a month, and if anything changes, that they definitely have it reevaluated. Now, looking at cyst, the cysts that patients come in with that are palpable are tension cysts. They are the cysts that are under pressure. These other cysts, I call these lazy cysts. These can be big, huge cysts, but they're not under pressure. Rarely are these palpable. In fact, next time you have a patient that you see one of these in, take your finger, run it over it, see if you can even feel it, but it just sort of feels like normal tissue. These tension cysts can only be a couple centimeters or a couple millimeters actually in size, but they're very palpable because they're under pressure. A lot of times on the lazy cyst, what you may be feeling is more of the fibroglandular tissue that extends up over it. So here's a patient that came in with a palpable lump. Sonographer was great. She did all the palpating, felt where the lesion was, put the transducer down, boom, there's a cyst. But what kind of cyst is that? It really isn't a tension cyst. By going back in and doing simultaneous palpation and scanning, what she was feeling was this isoechoic fibroadenoma. Now, cysts are so common. Just because you see a cyst in the same area as a palpable lump, don't assume that that is what the patient is feeling. Make sure you do the simultaneous palpation and scanning. Standoff pads are something that we use quite often if we're dealing with lesions that are too close to the skin, if we need to move something closer to the elevation plane focus. Now, for any of you who've been doing ultrasound for quite a few years, you're going to remember those 3-centimeter standoff pads that we used to use for general imaging. You want to make sure that you're not using a standoff pad that's 3 centimeters thick, or your beam will be focused right in the middle of it. Typically, you want to use a standoff pad that's a centimeter in thickness or so, but what's the problem with standoff pads? Once you get them placed on the breast, and if the indication was a palpable lump, you're no longer able to palpate the area that the patient was feeling. I don't know about you, but for me, I always seem to get air bubbles trapped under there. So you're scanning along and all of a sudden you run into an air bubble and you can't see anything behind it. But the thing I really hate is when you're scanning, you're looking at your ultrasound screen and you figure out, what on earth am I seeing here? You look down at the patient and the standoff pad has now slid all the way up to her thyroid. Instead of doing a breast ultrasound, you're scanning her thyroid. So instead of using standoff pads, what I prefer to do is just use a big glop of gel. And the problem with using a big glop of gel is when you put your transducer down, all the gel smooshes out. So you end up by squeezing another big glop of gel. I'll show you a trick that you can use. If you take your little finger and put it underneath the edge of the transducer, when you put the transducer down, you now have a built-in standoff pad. It makes it great. You're not having to use all that gel just for scanning one little area, and you don't have any air bubbles that get trapped under there. This is called the wrap technique. Looking at the near field volume averaging, this is a patient that presented with a palpable abnormality. Now you're like, where is there even anything palpable? But several things wrong with this image. You can see this is kind of the area that the patient was feeling the lump. This is 1 centimeter right across here. So we're scanning something within the first 5 millimeters. And the other thing, remember when I first talked about focal zones? Somebody forgot to move their focal zones up to optimize this image. So once we use a standoff pad of gel, we move our focal zones up. You can see that we actually have a small cancer sitting right here underneath the skin that could not really even be seen here without optimizing our image. So remember, elevation plane focus, where's the beam focus the narrowest, and be sure and keep your focal zones moved to where the area of interest is that you're looking at. Split screen imaging. This is when we're comparing right side to left side. So with mammography, what we're looking for a lot of times is any asymmetric tissue density. And on ultrasound, if there's asymmetric tissue density, we want to do mirror image split screen images comparing the right to the left side. So here on this mammogram, you can see that there's water density in the right axillary segment of the breast. When we compare it to the left, there's just normal fat on that side. So on ultrasound, we go into split screen. You can see that we've got normal fibroglandular tissue that corresponds nicely to what we're seeing on the mammogram. We've got fat in the left axillary segment that compares nicely to what we're seeing there. So one ultrasound image can show you the asymmetric tissue density, same as to what we're seeing on the patient's mammogram. We'll also do split screen imaging to check the compressibility of lesions. If we're going to call something a lipoma, we like to see it compress 30%. Fibroadenomas may compress somewhat, but rarely over 25%. And some of your cancer, especially the highly cellular ones, may compress, but rarely over 15%. So this is a patient presented with a palpable lump. Looks like it's a lipoma, but one more thing we like to do just to prove is to check the compressibility. So we'll go into a split screen image. The first image we take with very light pressure. Lighten up, add extra gel, lighten up your pressure so you're barely making contact with the skin. On your next image, switch to the other side, compress down, and we like to see at least a 30% compression in looking at these lipomas. Now sometimes you'll have lipomas that are more echogenic. Those will not compress the 30%. The ones that we see 30% compression are the isoechoic lipomas. Looking at this lesion, is this a fibroadenoma or could this be a trapped fat lobule? Now one thing you'll notice on fibroadenomas will allow 3 gentle lobulations. This has more than 3 gentle lobulations, so this would be given at least a BI-RADS 4A. I'll show you 3 maneuvers that you can do to try and prove if you possibly could be dealing with a fat lobule versus a fibroadenoma. First thing, check compressibility. Does it compress 30%? Now, just the normal weight of breast tissue, if you're dealing with fat that's deep in the breast, you may not get the 30% compression that you will on more superficial lesions. The other thing is just take your transducer and start rotating it around. See if it hooks up to the retro or supramammary fat. And the third thing is look for the straight white line. Anywhere that I have compressed, you can see this white line. Now, if you lighten up your pressure, the white line will go away. Compress down, it'll come back. What this is, if you've ever seen fat, fat's not just a sheet in there, it's one glob of fat up against another. So what we're doing is catching the interface of one fat lobule against the other one. If you lighten your pressure, the interface runs up at an angle so that we're not seeing it, but as you compress down one interface to the other, you are now scanning that at 90 degrees, so you're able to see the interface from one fat lobule to the other. Beware, fibroadenomas may have echogenic lines. On MRI, they're called the sapphire sign, but they tend to be more on the periphery. And also, any lesion that would have had a previous biopsy, you might see the scar through that, but that will be there no matter whether you scan with light pressure or heavy pressure. With these fat interfaces, as you lighten your pressure, you're going to notice the white line goes away, and then as you compress, you'll notice that you see it more. Variable compression with 2D imaging. We'll also do split screen. Fibroadenomas can be in a rotation that they possibly could be in a non-parallel axis or a taller than wide. But cancer, if it's in a taller than wide axis, no matter how hard you push, you cannot get it to rotate. This was a patient that presented with a palpable lump, and scanning with normal to light pressure, you can see what looks like a fibroadenoma, but it is in a non-parallel presentation, or same as taller than wide, and that is a feature worrisome for malignancy. If we compressed, we could actually change the orientation of this and make it parallel to the skin. This particular patient elected to not have a biopsy. We followed her for 3 years out, and this never did change in size. The other thing that can happen is if you scan with too light a pressure, you can actually get shadowing from a Cooper's ligament. The Cooper's ligaments may be running up towards us, but by compressing, you can flatten those out. Here, scanning with very light pressure, this looks like a fibroadenoma, but we have shadowing behind it. Shadowing, remember, is a feature worrisome for malignancy, but by compressing, we were able to make that shadowing go away. This was just an artifact on the shadowing, and compression can make it go away. I would say about once a year we would get a patient that would present with a palpable lump. You can see that her palpable lump is a simple tension cyst right here, and on her mammogram nothing showed up else in the breast, but you can see this area, small breast cancer, sitting right next to the cyst with intense shadowing behind it. Now, with breast ultrasound, a lot of times we become very tunnel vision. We see these really small cysts in there, we're trying to clean them out, we're trying to show the through transmission and good posterior borders and enhancement, and we become so tunnel vision that we take a picture that looks something like this. This looks just like the cancer I showed you sitting next to this cyst. If this patient has films that are red at the end of the day, she's going to be recommended for a biopsy. But this was just created by scanning with too light a pressure. Once we went back over the same area, compressed down, we can completely make that go away. So it was an artifact of just the normal fibroglandular tissue with scanning with too light of pressure. Now, one of these is a cancer and one is not. And usually I'll ask people who thinks this is a cancer and who thinks this one is, but nobody guesses anyway. But my main point is just to show you that you can take perfectly normal tissue and make it look just like a lesion. And all I did was lighten up my scan plane. If you scan with too light a pressure, you can take perfectly normal tissue and make it look like there's a lesion there. So ultrasound requires variable scanning pressure. If you're scanning looking for the presence of blood flow or color Doppler, you need to scan with very light pressure. If you're getting what looks like shadowing, you need to compress and make sure that it's not artifactual, but variable compression is what's necessary for breast imaging. The last thing I'm going to talk about is imaging the nipple. A lot of times people think that on ultrasound we really cannot image the nipple. One reason is if we look at the ducts and how they run straight up towards us if we're scanning in an AP projection of the nipple. Now, anything that's running straight up towards us is going to create an artifactual shadowing. So we need to come up with a maneuver or something that we can do to be able to evaluate actually within the nipple. And the way that we've done this is a couple different approaches. Now, if we're scanning the nipple in a straight AP anterior projection, you can notice We have intense shadowing behind the nipple. This patient had presented with bloody nipple discharge, and we can see that there is some ductal ectasia here, but we really can't see anything else going on within this patient. So one thing we can do is just called peripheral compression. If we take the transducer and just sort of roll the nipple onto its side, you can see that we're able to scan more of that ductal system, but we still are getting some shadowing coming out from the ducts because we just don't have the right angle that we need to image that. We can do a two-handed compression. So what I will do is take my free hand, push up on the breast, take the transducer and push up on the other side, and what we're able to do is see more through that ductal system, but we still are getting some shadowing coming in. So the way that we can image directly through the nipple is if we do what's called a rolled nipple technique. So we take our free hand, take the index finger, lay it up against the nipple, take the transducer and compress the nipple over our finger. Then what we're able to do is scan the entire nipple all the way through. So this is my index finger here. This is the patient's nipple. You can see that we're able to see the duct all the way into the nipple, and then we would line it up with the additional views that we had with the two-handed compression and peripheral compression to evaluate the rest of the ductal system. But in doing these different maneuvers, we are able to evaluate the nipple with ultrasound and not get intense shadowing behind it. So once you all understand breast sonography, you'll love it. Have a great day.